this morning on the morning news on CBS, they had a young man on who was in his 20s, and he was in fantastic shape. He had had stem cell transplant, where they do like the chemotherapy thing, and he's been perfect for 3 years. They said there were 22 people in the study, and they, of course, they didn't say anything about the other 21. And so I don't know, but it was some sort of a study they did at Northwestern University, and I can't remember the name of the doctor.
Dr. Burke.
Dr. Burke?
Yes, that was.
Yeah, so I'm not seeing him present.
So they're going to be doing another study, but, he was very young and probably very good shape when he was diagnosed in his late teens.
Yeah, so again, and you hope they do the next time blinded. So, or at least blind. So you understand there's sort of different ways to do these studies. So the best way is everybody be blinded. The doctors don't know, the patients don't know. That's usually not possible for such an invasive thing like this. So then what you try to do is the next best thing where at least the doctor who's monitoring the patient doesn't know. So the patients come into the study and they're randomized to 2 groups, so-called standard therapy, okay, would be appropriate for this because if you're going to study follow folks for like 5 years, you don't want folks to be on placebo for 5 years, versus this new intensive therapy, and then every 3 months or 6 months they see some sort of physician. He doesn't know which arm they're in, the patients are supposed to not say anything. And then normally, quite frankly, for these studies, a lot of people are using MRI outcomes because number 1, they're cheaper, number 2, because they're blinded. So you send the MRIs get done here, but they're sent off to Canada or UT Houston or central reading stations where those doctors have no idea what's going on. And then you look at MRI stuff over years. So again, I think it's a great, I think the next 5 to 10 years is going to be different than it has been. And when I started my practice, there was no treatment for MS. Beta-seron just hit the market. Of course, it was kind of sold to Congress as the FDA has to approve this because all of our MS problems are going to go away if only the FDA will approve this drug. And it's horrible that the FDA wouldn't approve it at first. Of course, the FDA wanted to see improvement in disability. They didn't get it in 2 years. They approved the drug because of improvement in relapses and because of, quite frankly, pressure from Congress. Okay? So, that sort of sets the tone for everything in MS to come after that. So we get lots of stuff on the market that improves relapses that only later do we get the disability data for. Unfortunately, they have correlated to this point. So we seem like we're doing okay. Yes, sir.
And patient advocacy is very important. Speak to your congressman, state and federal congresspeople. Call them, write them, email them.
The best time, by the way, to meet your congressman is when they're not in session. So if you really want to have an impact on your congressman, when they're not in session, catch them at their local offices. And I'll assure you, if you show up at their office, and they have some paid lobbyist person there, that person will wait for you to go and talk to them. So they actually always are happy to see constituents. When they're in session, you can imagine they have a million things on their time. Like, hopefully some of them actually read what they voted on. I doubt it, because it was 900 pages and they got it for about a week. And I can't read that, But you can imagine they have a lot more made on the time. So they're in session now, certainly you can advocate now, but the best time to talk to them is when they're actually not in session.
I have a question. What is the data over the years of the effect of MS on the cognitive portions of the brain?
Yeah.
Do we know anything about that? The ability, the thinking portion, being able to process data, do we have any information?
Yeah, so in the pre-Beta-seron era, okay, where you could have natural history of the disease followed for 10 and 20 years, we have that. You kind of had the rules of a third, where a third of the patient did very poorly, okay, and a third had some problems, and a third did really quite well. We think we've now, with treatment, we've kind of shifted, and more patients are going to do well, but since, Beta-seron's been on the market for I don't know, my math is off, about 19 years now, and Copaxone about 17 years now, something like that. Okay, only, people weren't set up to do those studies. I mean, we just don't have as much of that as we like. And cognitive testing is very expensive to do well. So even the long-term trials where everyone is using the EDSS, which is not a cognitive test, and only recently have we done to do anything, and quite frankly, all they're measuring now is math. So they have something called the PACE-app where they read you numbers and you have to add them up as a cognitive test, and we've only been using that in studies for about 4 or 5 years now. So it'll be a decade or two before we have more data on that.
There is about a 3.5-hour test. Are you familiar with that?
Neuropsych testing.
Yes, neuropsych.
It's just expensive to do on a regular basis for studies to kind of gather this information. That's the
And
problem.
have you ever taken that? Okay. It's neuropsych, and that one's,
If you're trying to get disability based on cognitive issues, that's what you have to go do in order to measure how you're doing. What they do is, since they don't know, since the test is trying to show disability from where you were and they haven't met you before, they look and say, okay, you're a college graduate in English, so therefore we expect you to have these IQ points in this problem, or you're a scientist, so you should do that. And it's working pretty well. And I think around there I'm going to stop because I think I lost my timer when my phone went off. But I think that's probably about time. So with this, I'll turn over to our next speaker.
Thank you.